to me.
I never thought it would happen to me. I didn't know women my age were at risk for heart disease.
Heart attacks are by far the most common cause of death in the United States of America. Many occur with no warning symptoms at all. Cardiovascular Institute of the South is the leader in treating cardiovascular and peripheral vascular disease. If you think you may be at risk of having a heart attack, come see us at any one of our 11 locations. Even the very best heart care is of value only if you have access to it. So here's our pledge. If you have chest pains or symptoms of a heart attack, you'll be seen at any hour, day or night. If you don't have symptoms, but you or your doctor have concerns about your heart, you'll be seen within 48 hours. And even a routine heart check will normally be scheduled within a week. CIS is one of the largest, most advanced facilities in the South with an international reputation for treating heart disease. Call us to schedule your appointment.
Welcome back to our live call-in show. We'll come back to the last 15 minutes to this discussion of when and why should I see cardiologists. Again, I have with me Dr. Cavros and Dr. Orzola in this lively discussion. And I also want to encourage the audience to call the number at the bottom of their screen. It's a live call-in show and this discussion about a very broad-based discussion about cardiovascular risk factors and how to diagnose cardiac vascular diseases. And in the last session, we'll briefly touch upon some of the treatments for cardiovascular disease, and the audience is certainly encouraged to call in with any pertaining relevant cardiovascular questions. And Nick, once we do have the diagnosis of heart disease, we are concerned about an abnormal stress test to begin with. How do we approach, and I'm sure for us it's just like routine after many, but how do you go about just advising the patients about the angiograms or the other more invasive tests? And do you use CTA or CT angiogram? And if you do, when do you lean towards CT angiogram?
Sure. In patients who have symptoms and have, quote, failed the stress test, if their symptoms are significant enough to not withstand medical therapy and not do well on medical therapy, then certainly they are kind of triaged to have a further more invasive test. And that more invasive test is a heart catheterization, or as we call it, a coronary angiogram, a left heart catheterization. And what that entails is we go in through one of the arteries of the body, either in the arm, the wrist, or much more commonly in the United States in the groin, and manipulate very, very tiny catheters up to the heart where the tiny arteries that feed the heart are located. And then we inject dye and take pictures with dye on a camera. This way we're able to get with various views a very complete picture of what the arteries look like and if there are any significant or even insignificant blockages. The test itself, I always caution the patients, it's an invasive test, and with invasive tests come some risks. Nothing we do in life is without risk, and certainly when we are up near the heart with catheters, one can understand that there are some risks involved with that as well. The major risks that we tell the patients are bleeding, infection, of course, having the need for urgent open heart surgery, having a stroke, and having a heart attack. Those are the main risks. In the general population, that's probably in the order of 1% or so. And as you get a younger population, it's less, and in the older population, it's more. If we go on to do any stenting or angioplasty, that certainly increases the risk, and it goes anywhere from 2 to 5% depending on the patient's substrate. So we then weigh the risk of the procedure against the potential benefit of the procedure. And if the risk of the procedure is less than the benefit of the procedure, then we feel safe advocating that to our patients.
Right, that's exactly a very definite paradigm that we all follow, like looking at this approach at angiogram. Certainly things have come a long way from when we started training. The catheter sizes were a lot larger. Now, these days, we are using 4 to 5 French, which is a tiny few millimeter catheters, get in there and safely complete these procedures, with much under 1% risk of having in a typical angiogram without angioplasty. Your risk is somewhere about less than 1%. And again, and if you do and anywhere goes up to 5%, when you take out all comers in a day, you have a 40, 45, 50-year-old or an 80-year-old woman with completely clean coronaries, and your angiogram is done in 5 minutes, and they're gone home in 2 hours, versus the other types of patients with multiple blockages in every possible area, and where you elect sometimes, if the blockages are too numerous for us to do stenting, you end up sending them to bypass surgery, and if the blockages are limited in 2 or 3 locations, or in this day and age we have gotten beyond that. With the advent of these medicated stents, it seems like the data and the knowledge that we are getting supports the usage of medicated stents in multiple locations, even including the main artery, so-called left main, the mother of all arteries in the body. The data supports the use, albeit with a great deal of caution, in the main artery. But the Achilles heel of using the medicated stents, we are taking it to a new level here, but is the commitment to blood thinners for prolonged periods. And you have an 80 or 70, 80-year-old woman or a man with a potential risk of bleeding due to diverticular disease, potential risk of falls, and different kinds of potential risk of sudden requirement for whatever surgery. Different types of things. It becomes a problem. You put a stent or 2 or 3 stents treating blockages. They're committed pretty stringently to blood thinners for at least 1 year, probably longer. And then if they require any other surgeries, we are putting the patient at grave danger by stopping these blood thinners, because these medicated stents do not heal as fast as the historic or non-medicated stents we used several years ago. But of course, looking at all this in a wholesome manner, still we would go on somewhere upwards of 20% of the time. Within 6 months, we would go and repeat angioplasty in the previous era. With the advent of medicated stents, our repeat intervention rate fell down much below 3%. And that's really a great boon. All in all, it's a great blessing to the patients. There is no discussion about that. But it's just that I also want to digress and talk about CT angiography as a little modality that we have come to use. And of course, in a patient that has a lot of symptoms, if he presents to the emergency room, or if he comes to us and clearly there is evidence of a very strongly positive stress test, in my practice, I feel the necessity of CTA to be a bit redundant, that you just go and do an angiogram where you have not only the ability to diagnose the problem with more certainty, you also can go ahead and treat it with stenting or balloon angioplasty and so on. Whereas if you take a patient that is relatively young or otherwise deemed somewhat low risk for having cardiovascular disease, and if their arteries don't have a lot of hardening, so it really boils down to a smaller subgroup of patients where we lean towards and do CT angiography. At the current state of affairs, it seems like CTA with the moving heart, you have to slow down the heart, you have to, and the patient has to cooperate significantly by holding their breath and to tolerate. And I mean, it's still fairly simple, but still has limitations. You do a CTA, it's inaccurate, then you're going and subjecting them to angiogram again, thereby increasing the risk of radiation exposure, as well as increasing the risk of dye and the procedural cost and all these things. So while CTA has definitely initially come on with a lot of promise, seems like we are using it more extensively in the arena of peripheral vascular disease and carotid disease. And with coronary disease, still seems like the traditional angiogram that is done in the cath lab still, to me, remains a gold standard. I mean, do you agree with that?
I agree. I think that, I reserve coronary CTA for those patients who have had a good stress test, doesn't show any disease. They've gone back to their primary care and or maybe a gastroenterologist, and they've said, no, we don't have reflux here or any stomach problems, and they continue to have pain, and then still, my suspicion is somewhat low. I don't want to subject them to an invasive test, so this would seem like an attractive alternative, the CT angiogram.
The beauty of that is you also get the information from the CT.
Exactly.
I think that CT angiography, where it's going to get better, is when the software for the study improves and you're able to do a gated study quicker and get the information a lot quicker. Where that is down the line, probably it should be soon. I don't think it's going to take that long.
Definitely, the technology has made tremendous progress since its inception in the past 5-6 years that we have used it in clinical arena. and certainly MRI also has made progress. But all these tests, but finally boiling down to why and when we need to see, bottom line of this discussion is to raise the awareness of these patients. And all these things are great. They are the final kind of a last ball down, and it's certainly to take care of these problems, improve the quality of life. After you improve that, you go back and doing the same thing. This is what happens, and I think the education part, which we could not do enough, could not emphasize enough, day in and day out, we keep nagging patients on TV shows and in individual day-to-day interactions with them. We constantly keep nagging them in a way, just advocating, eat less or cut down your portions. A little bit of good stuff, not a lot of good stuff.
Yeah.
Try to get a little more active. Increase your awareness. Understand your cholesterol. Understand your hypertension. Understand your diabetes risk. Understand your family history, which is one of the biggest risk factors of potential for cardiovascular disease. We encourage them again and again and again. These are very basic 5 to 10 steps. If you follow them religiously each and every time you encounter a patient, you're likely to hit it 9 out of 10 times. You'll pick them up.
Let me just say the concept, and I'll be quick. The people need to understand that this is not, the treatment of the disease is not the stent, it's not the bypass surgery, it's not the putting in of the balloon. The treatment of the disease is the pressure control, it's the diabetes control, it's the cholesterol control, it's the weight control, it's the exercise, it's the diet, it's the getting rid of the cigarettes. That is the treatment. Everything else is palliative. People need to understand that when they put in a stent, they don't take the blockage out, they squish it against the walls. When you do the bypass, you don't take that. You're doing a bridge over the lesion. So you need to get this concept in your head that this is just palliative. It's just helping relieve symptoms, allowing the treatment to take effect, because the treatment is long-term. It's for the rest of your life.
Classic people come in, have their stents, have their bypasses, and said, "Doc, do I need to take all these medicines still?" And this is classic, and I think to your point, it is a process like diabetes. Once it sets in, unless you're really religious about modifying your risk factors, controlling your diet, controlling your blood pressure, controlling your sugars, and so on, it doesn't go anywhere. It sets in. The studies have shown when you do all the above right things and control your cholesterol rigidly, the plaque or the lining, the damaged lining may stabilize and maybe even get better a little bit, but it's just a minuscule of a change.
Correct.
The burden of the disease is enormous. And you have kind of abused, for lack of a better term, all of us have abused our bodies with all the above bad habits for many, many years and decades. And it surfaces when you're 70 years old. It's not going to go away just because I and you or Fernando go in and do an intervention. So Nick, it looks like we're coming to the last minute, and I'm really happy that you joined us and practicing
Thank you. It's good to be here.
with us here, and I'm sure you'll find this a very rewarding experience, helping out and getting all the good graces of the patients. The patients certainly are highly thankful and appreciative of the little services we are able to provide them over many years, and I'm sure very quickly you'll be able to appreciate that. We welcome you on board.
Thank you so
Practice in Lafayette. Certainly we'll all be crisscrossing with some of our joint efforts with Lafayette General as well, but I want to repeatedly invite you and John Patterson as well to come and share your valuable thoughts on this show. And Fernando, I want to thank you for coming in and saying it bombastically about your views about the cigarette smoking and all the risk factors. I mean, there is no sugarcoating in this business. And this is the reality. You come in there, you're paying us to tell you like it is.
Yes.
So with those remarks, we'll take leave from you all, and we'll come back the second Tuesday of each month for our live call-in show from the heart here at Appaloosas General. We are from Cardiovascular Institute of the South, and good night.